Today we're diving into a structured review based on the work of Dr. Reza Lankarani of the Liveration trial.
Right, this is the big international trial looking at additional margin coagulation, or AMC, after liver resection.
Exactly. And the core question is, does it reduce local recurrence? But the real ambition here seems to be about redefining what an R0 margin even means.
Moving from pure anatomy to a more functional adequacy.
So let's start with the strengths. The review rightly highlights the pragmatic design. It's built for, maximum external validity.
For real-world applicability.
Yeah, and that careful balance between rigor and what actually happens in a hospital is what jumps out first.
But that pragmatic approach, it's a bit of a double-edged sword, isn't it?
How so?
Well, the pragmatic design, while it's fantastic for generalizability, it creates a real tension when it comes to analyzing confounding surgical variables.
You mean because they're allowing for so much variability? Different chemo, different centers, even surgeon-chosen techniques.
Precisely. The weakness is that the study acknowledges this heterogeneity, and the plan is to use a mixed effects Cox model to adjust for it.
Which is a robust statistical tool.
It is, but relying only on statistical adjustment after the fact, it could really dilute the results.
Ah, okay.
I mean, what if there are these big, unmeasured imbalances in just core surgical philosophy, things outside the AMC intervention itself?
So you're saying the trial could end up measuring the effect of a hospital's pre-existing surgical culture, not just the AMC?
That's the risk, yeah. So the suggestion for improvement is to proactively detail sensitivity analyses.
Ones that are specifically designed to isolate and test the influence of these high variability factors.
You have to show foresight. Show you're guarding against the known limits of a pragmatic trial.
That makes a lot of sense. You need to prove the result holds up no matter what a center's baseline surgical style is.
Exactly. So for a concrete example, you could specify a sensitivity analysis that looks at LR outcomes based on a center's, let's say, typical historical R0 margin philosophy.
So you'd compare outcomes in centers that usually aim for a big 1 centimeter margin versus those that are okay with, less than a millimeter.
Right. And if AMC benefits both groups equally, your evidence becomes so much stronger.
But how would you even document that? A center's historical philosophy sounds kind of subjective to define for a protocol.
That's a fair challenge. You could do a baseline survey, maybe use registry data for each center before they even enroll anyone.
Or maybe have the lead surgeon declare their intended margin strategy before the operation even starts.
That would work too. The key is just showing you're aware of the confounder and you're trying to control for it.
And what about the actual operation itself? The complexity?
Another great point. You should pre-plan an analysis looking at whether the benefit of AMC is different based on the type of resection.
A major anatomical resection versus just a limited wedge resection?
Yes, because those factors really dictate the pressure on the margin width. If you can show AMC is the great equalizer, no matter how complex the surgery is, then that functional adequacy argument gets a massive boost.
Okay, let's pivot to that very idea, the core objective of redefining the R0 criteria.
Which is compelling. It's a transformative concept for surgery.
It really is. The material makes a strong case that this trial tackles the dilemma of what to do when wide margins are just anatomically impossible.
I completely agree. But to maximize the impact of potentially redefining R0, the protocol needs to explicitly link that functional intervention, the AMC, to something you can measure early.
An intermediate quantifiable endpoint.
Yes. Right now, there's kind of a gap in the data stream. It's a great hypothesis, but it needs better mechanistic validation inside the trial itself.
To show how the functional change is happening.
That's it. The weakness is this timeline mismatch. The goal is huge, redefining R0, but the secondary endpoints are all long-term things like survival and complications.
And the 1-month post-op measure is just the transection area, which is purely anatomical.
Pure geometry. So if AMC works by sterilizing the margin, which is the core idea, there's a missing link. You need a measure of functional success long before you get to the 3-year primary endpoint.
So if the trial is positive, you're left with this big explanatory hole. You know it works, but not exactly why or how. You need a proxy for that sterilization effect much earlier.
You need to bolster that area. The suggestion is to introduce a secondary endpoint or maybe a substudy that quantifies the biological effect of the thermal margin itself.
Building the evidence base for functional adequacy well before the 3 years are up.
Exactly.
The future plans do mention biomarker studies. What kind of markers could give them that kind of rapid feedback?
Well, the most cutting-edge option would be to look at circulating tumor DNA, ctDNA clearance.
Okay,
You could measure it at the 30 or 90-day follow-up. And if you can correlate ctDNA clearance, the tumor DNA vanishing from the blood, with the use of AMC,
You'd have a rapid biological validation of the whole sterilization hypothesis.
that's it. If the heat is killing microscopic disease, you should see it in the blood much faster than you'd ever see it on a scan.
I love that idea. But ctDNA, that's a huge logistical and, frankly, financial cost to add across 24 centers.
It is. It's a big ask.
Is there another way, maybe something using the imaging data they're already collecting?
Absolutely. You could leverage the existing central imaging review. So instead of the radiologist just measuring the surface area, you could task them with quantifying the volumetric depth of the thermal coagulation zone that's visible on the post-op scan.
That's brilliant. That moves the assessment from a two-dimensional plane to a three-dimensional volume of treated tissue.
And now you have a quantitative radiographic measure of the functional margin you've created.
Exactly. And it would also help validate the consistency of the thermal effect, which I think brings us to our next point.
The intervention itself.
Right. So we've talked about confounding factors and outcome metrics. Let's dig into the technique.
Okay.
The commitment to quality control is clearly there. They specify approved devices, Coolingbis, Aquamantys. The training is specified. That's all excellent.
It's essential for sure. But the success of the whole thing really hinges on the execution of the AMC. And relying on a subjective painting motion technique,
Especially across two very different devices.
it introduces a ton of potential variability right into the core treatment arm.
It's the classic problem for any multicenter surgical trial, isn't it? How do you standardize an action that is just, by its nature, operator-dependent?
And when the tools are so different, that's the weakness here. The protocol describes it as a painting motion for 15 seconds to get complete surface coagulation.
But you've got one device at power 7 and another at 100 to 120 watts.
The power ranges are worlds apart, so this qualitative definition poses a major risk of high interoperator variability. It could totally obscure a real treatment effect if the actual dose of thermal energy being delivered is all over the place.
So you're not even comparing apples to apples within the intervention arm itself.
You might not be. That's the risk. So the suggestion is to bolster the quality control by translating that qualitative training standard, the painting motion, into quantitative verifiable metrics.
Things that can be documented right in the electronic case report form.
Exactly. Turn the guideline into a hard data point.
So what's a good way to get that quantitative metric without adding, huge burden in the OR?
The most straightforward step would be to mandate documentation of the estimated ratio of total coagulation time in seconds to the transection area in square centimeters.
So that ratio becomes a kind of surrogate for energy dose per surface area.
Precisely. It makes sure you're applying proportional effort to a small resection surface versus a huge one. It's actionable, and it gives you a verifiable measure of technical effort.
And to make sure that data is actually reliable?
We go back to our objective check. The central radiologist who's reviewing the post-op imaging.
The one who's already quantifying the depth?
That's the one. They should also be specifically tasked with grading the uniformity and the continuity of the thermal lesion at the margin.
So it's like a post-op audit of technical fidelity.
Exactly. If the lesion is patchy or inconsistent, it doesn't matter what the surgeon wrote down. You know there was a technical failure in the painting motion, and the analysis can account for that.
That really closes the quality control loop.
It makes the whole intervention arm much more robust.
Okay, so to recap, we've really covered 3 critical areas to strengthen this trial protocol. First, improving how surgical confounding variables are managed.
Right. Second, better operationalizing that definition of functional margin adequacy.
And third, really standardizing the fidelity of the AMC intervention itself.
And implementing these actionable steps like the sensitivity analyses for resection type, integrating early markers like ctDNA, or quantifying thermal depth on imaging, and adding quantitative metrics for the painting motion.
All of it helps ensure that when the final publication comes out, it's delivering the most robust and compelling evidence possible.
It really shores up the entire foundation of the trial's hypothesis.
We would love to see how these suggestions are integrated into the next draft. This critique was based on the structured review prepared by Dr. Reza Lankarani, general surgeon and editorial board member at the Genesis Journal of Surgery and Medicine.
To access additional details, you can refer to the Surgical Pioneering podcast series application.
The link is available at surgicalpioneer.codx.me. We invite you to submit your work again soon.